Good afternoon, everyone. Paul Kelly here in Canberra with an update on the COVID-19 situation here. So just going through the numbers, first of all, another very good day in terms of the epidemiology of cases in Australia. Only one locally acquired case in the last 24 hours, and there were 16 cases altogether, the rest in hotel quarantine in those that had returned from overseas. Compare that with the rest of the world. What's happening in the rest of the world? 685,000 cases in the last 24 hours. 685,000 versus 16. And 16,000 deaths, more than 16,000 deaths around the world. So many countries much worse off than us at the moment. We've got 46 people in hospital, and I'll just to talk a little bit about hospitalisations. Almost all of those that are in hospital are there to isolate those cases from the rest of the community in a couple of states. That's their policy to do that, and so that's not necessarily a measure of disease severity. There's only one person in intensive care. We've seen in many countries in the world intensive care units and hospitals totally overwhelmed, leading to the building of temporary wards and so forth in many countries. So Australia is in a good position. Just related to that, we have a definition of a hotspot at the Commonwealth. This is mostly to relate to Commonwealth support to states, particularly in aged care. So there's a range of measures we put in place once the Commonwealth hotspot is declared. I've done that as Chief Medical Officer twice. Once was on the 18th of December in relation to the Northern Beaches LGA in Sydney. So today I'm revoking that hotspot definition on the basis of the fantastic work that's been done, of course mainly by the community in taking note of all the public health orders and the lockdown measures that have happened there over the last few weeks, but also to the tremendous work that's been done by the public health officials in New South Wales. So that hotspot is revoked. I did declare a hotspot in Brisbane last Friday in relation to the cleaner from the quarantine hotel and that abundance of caution because that cleaner has has been proven to have one of the new more transmissible strains, the B117 strain, which is now affecting 6 people in that cluster. I would say in relation to that all of those cases are in isolation or quarantine. So 4 of those cases have come from overseas. The other 2 is the cleaner and her partner, but they are all isolated. The Queensland Health and Australia's most experienced Chief Health Officer, Jeanette Young, was talking about that earlier today, and we talked about it again at AHPPC in the last hour or so, and of course we're putting in any supports that Queensland Health needs to deal with that particular issue, and all of the Chief Health Officers in all of the states and territories are also standing by to assist. In an abundance of caution, and we totally accept and agree with Jeanette's view on this, Dr. Young's view, that she will be contacting anyone who has been in that hotel during the period of concern, either staff or people that have arrived overseas, whilst they're working out how that UK strain, the B117 strain, may have spread between rooms and also to the cleaner. Once they're working through that, they will be asking anyone that's been in that hotel, either as staff or as people that have returned from overseas, to isolate and get tested, and then they'll be contacted by whichever public health authority of that state or territory they are in for further information and advice. The other news item of the day, I guess, is in relation to the Astrazeneca vaccine and our vaccine program more generally. I've just been part of a briefing to the press, and I see a couple of the people that were on that phone call are here in the room or online on the phone. So we gave a briefing about the vaccine strategy, and just to really be very clear about some of the claims that have been made by some people in relation to the Astrazeneca vaccine. So I just want to be very clear about that. What we know about the Astrazeneca vaccine, it's one of the 3 vaccines that have had published their interim results from their phase 3 clinical trials. That particular vaccine, the Astrazeneca vaccine, was published on the 8th of December. There is the article. I read it on the day that it was published. That was more than a month ago. And many underlines there you'll see. So I know that data well. Some people have been taking particular parts of that article and not reading the whole article, in my view, about how effective it is or isn't. So I just want to be very clear. The AstraZeneca vaccine has several reasons why it's very important for our vaccine strategy. Firstly, it's being made here in Australia. There will be enough vaccine very soon in Australia for Australians to be able to vaccinate any Australian who wants to be vaccinated against COVID-19 this year. The AstraZeneca is here. We don't need to queue for that. That is being made in CSL right now in Melbourne. Second of all, it is very effective against severe illness. It will save lives. By using this vaccine, we'll be able to protect a large proportion of the population in Australia, whoever wants to have that. We also have 10 million doses of the Pfizer vaccine. That will probably be the first to get the full tick from TGA. We expect that in very soon, within the next few weeks. And we'll be able to start our vaccine program with the Pfizer vaccine, as was announced by the Prime Minister last week. And so that Pfizer vaccine, very important. That's our priority group, so we'll be starting there with our quarantine workers, with our border workers, those at highest risk of exposure, as well as our healthcare workforce, our aged care workforce, and then moving into aged care itself as our most vulnerable Australians, the most vulnerable to severe illness. So I think I'll leave it there and ask for questions. Start with you first, Claire.
Professor Kelly, 2 questions if I may. The first regarding vaccine hesitancy. To what extent is that a concern for yourself and medical officials, and what are the major risks in potentially pushing people away from getting a vaccine when it is approved?
So yes, confidence is absolutely key here. We know that in vaccination programs broadly and in general, for many years Australians have been they've been great at taking up the office of vaccination for our children and more widely in the population. And we know that confidence is absolutely key to that. There are some people that just don't believe in vaccination. We can't convince them that the anti-vaxxer group is as they are. We know that the majority of Australians are in favour of vaccination generally, and our surveys that we've done in relation to the COVID vaccine have been very positive in that regard. There is a group, though, in between those two extremes, if you like, where confidence is absolutely the most important thing. And that's what worries me about the coverage we've had today in relation to the AstraZeneca vaccine. People will be nervous, of course, and we need to give more information, and we're doing that. So yes, I am worried. I am worried about the selective use of the data that we have, those interim results from particular studies back in November. And just to absolutely put it on the table today, that the TGA will go through all of the things they need to do, all of the usual checks and balances, and it's only when they have finished that full approval process that any vaccine will be available in Australia, including the AstraZeneca and the Pfizer vaccines. And so people should be confident about safety being our first priority, and efficacy being the second, and the quality of the vaccination of the vaccine production also being crucial. And we're working through all of the other issues around training our workforce, getting the logistics right, making sure the information is collected about who has had which vaccine, when and where, as well as any side effects that might happen as we roll this vaccine out.
And if I may, sorry, Queensland mentioned this morning that they would be bringing to AHPPC new ideas to deal with the more virulent British strain of COVID after it spread in a hotel there. Are you able to elaborate on what idea was brought forward, or what the process might be for changing how we deal with hotel quarantine?
So at National Cabinet last week, I was in the room when the Prime Minister and the Chief Ministers and Premiers of all the states talked about strengthening our arrivals process, and I would say an end-to-end approach to that, from before people leave another country to come to Australia. So the pre-flight testing concept there, and only people that are negative will be able to fly, right through safe flights in terms of infection prevention and control through that process on arrival in airports in Australia. And so mask wearing in particular will be compulsory in all airports, both domestic and international, in relation to that. But then the end-to-end in the quarantine process, the transport to the hotel, because we've seen transport workers a transport worker in New South Wales become positive in recent times, through the whole process of whilst people are in hotel quarantine, and we've seen those issues emerge this week in Queensland in relation to that, the cleaning process after people leave. So all of those processes are being looked at and will be looked at, and see what else we can do in relation to those procedures.
Professor, it sounds like you're hoping or expecting the Astrazeneca result will be much higher than 60 or 70%. Could you actually explain, I guess, what the difference would be in general terms of a vaccine that has 70% efficacy versus one that has 95%? Are we talking about quite a significant difference in terms of like a health effect of how good it is, or is it kind of a choice between a very good vaccine and a very, very, very good one?
So they're both good. So a couple of things I'd say there. The World Health Organisation, this was an agreement amongst experts, that their bar that they wanted all COVID vaccines to exceed is 50%. So 62%, 70.4%, 90%, 94.5% and 95%. So that's all the percentages for AstraZeneca, and their two different ways of giving the vaccine, Pfizer and Moderna, are all above 50. So these are all very good vaccines in terms of efficacy for symptomatic illness. Now, all of the three vaccines that have so far published their data in peer-reviewed journals, so that's AstraZeneca, Pfizer and Moderna, all show a very similar effect against severe illness. Basically, they're all extremely good against protecting against severe illness and death. So that's why I say that lives will be saved by the AstraZeneca vaccine. I have no doubt about that.
But in that interim between 70 and 95, how much, obviously that's 25%, but in terms of actual response, what does that mean?
So that's to be determined. I'd say that we've got those results from the interim trials, and we will see how that works in the Australian context over this year. So we're in a very different phase in the pandemic, but one thing that is against us in a way is we've had so few cases in Australia, so there will be very few people with the immunity that comes from having had the illness. So in many ways, Australia is at more risk from that point of view. So therefore, it's more important to roll out as much vaccine as we can, as quickly as we can. And so that's actually the counterfactual here. It's not whether one is better than the other. What do we have available? We have the AstraZeneca available for the whole country in Australia.
Why don't we have a contract to supply the Moderna vaccine?
So we're continuing our conversations with Moderna and a range of companies, around a dozen companies, I believe, at the moment we're in active negotiations with. And we are open to get more vaccine, but...
Shouldn't we have that now, though? Wouldn't it be better to have a contract with Moderna in place like we have with Pfizer? We can't manufacture an mRNA vaccine in Australia. We can't make them here. We're relying on overseas supply. Shouldn't we have a contract with Moderna in place now, given it's the other promising candidate?
It's a very promising candidate. David, I'd put it to you that a contract takes two parties to sign.
Were they not willing to share any of their supply with Australia?
We have continued conversations with Moderna, but it needs their agreement to sign such a contract. I'll leave it there. A lot of these issues are commercial in confidence, and I can't really talk to them.
And what about Johnson & Johnson, which is another possibility? Were they unwilling to make anything available to Australia?
So Johnson & Johnson have applied for a provisional designation, and so they're going through the pathway for approval in Australia. In terms of contracts of pre-purchasing agreements, again, I'm not at liberty to talk in details, but there were issues that we were not able to agree on with Johnson & Johnson, which was mainly in their court.
Sorry, that they did not have enough supply for us?
It wasn't a supply matter, but I can't talk in more detail about that. But we were unable to reach agreement with Johnson & Johnson.
Is that still in negotiation, or is that sort of off the table now?
That's off the table at the moment, yeah.
you mentioned about, I guess, the selective reading of data. The people who have raised these concerns are not crackpots, conspiracy theorists, they're not even coalition backbenchers, for instance. They're doctors, they're scientists, there's some people in this field. What do you say to them for putting it out there? You know, when people like Raina McIntyre, who, for instance, and not to single her out, but she's become a very high-profile person in this debate, when they talk about these things, people believe them. What do you sort of say to sort of come up against that sort of view?
Sure. Yeah. So I've known Raina for many, many years. We've been close colleagues over time. We have had our disagreements in relation to the way that these things should work, and she's entitled to her views. We have the main group that is advising the government on this is the ATAGI group. It's the Australian Technical Advisory Group on Immunisation. That's been present for many, many years, not just for COVID vaccine, but for all vaccines and all immunisation programs. They're the ones that are responsible for writing the Australian guidelines on immunisation. They are hand-picked experts to advise the Minister for Health. Many of those are prominent people you will have also heard of. Alan Cheng being probably one of the more prominent ones, who is the co-chair of that committee. So they're our experts. They've been involved with all of the information around the vaccines right throughout. We have another group called SciTag, which is the Scientific and Industry Technical Advisory Group. That's been specifically formed for the COVID vaccines because of the complexity of all of these matters that we're discussing today. They are also very helpful with their opinions and so forth. Both of those groups have been absolutely key in the advice to government about the pre-purchasing agreements and other elements of the vaccine rollout. And so those are the ones that we rely on, and I would suggest that people listen to those experts.
Can I follow up on Andrew's question? I write for the Sydney Morning Herald and The Age. We wrote the story today about questions over the Astrazeneca vaccine. I'm proud to work for those two papers. Our stories clearly said that the vaccine works and clearly said that the vaccine is safe. But the question is about whether its efficacy rate is as good as the Pfizer vaccine. Now, isn't there a fair public debate to be had about whether one vaccine is a better option than another?
It is, if the option was we could have one or the other soon enough to make a difference. So I'll say to you that we've had so few cases in Australia over the last year compared with many other countries that we are essentially completely non-immune. So the choice is not whether one is better than the other, it's which one is available to give the maximum rollout of vaccine to save lives and to protect lives this year. And the answer to that is the one we can make here. As you've mentioned already, we don't have the ability to make mRNA vaccine onshore. We have made the ability to make the Astrazeneca vaccine as a different version of essentially getting to the same endpoint. We've got that through CSL, so we have those doses onshore. We're not in any queue for those. I'll just go to the phone. You've been very patient. So Daniel Sutton first from Channel 10.
Sorry about the delay. My headphones just fell out. Thanks for taking the call. And the question, you're obviously aware of the criticism that's been levelled today about the AstraZeneca and Pfizer vaccines. We've obviously put a lot more money and resources into that AstraZeneca vaccine. Just simply, have we backed the only horse we could, but is it still a lesser horse? If that makes sense.
So I've had discussions about horses being backed and eggs in baskets today. So either one of those works. I think we've backed many horses or have several eggs in the basket. We have from the beginning looked for a diversified portfolio of vaccines. We chose one mRNA vaccine on the basis of the advice of the committees I mentioned before, that was the best option. That was the Pfizer vaccine in the mRNA group. We several months ago and even now, the AstraZeneca is an example of the viral vector technology. Both of those extremely novel new technologies for making vaccines for humans. So we took one of those, that was the Astrazeneca. We had a protein vaccine. Protein vaccines, much more traditional way of making vaccines, but they're slower. And we had the UQ vaccine, and for reasons we've discussed here before, we've had to pull out of that agreement because of issues in relation to the UQ vaccine. But we have always had a backup in the Novavax vaccine, which is another protein vaccine, and that's showing very strong performance and quicker than we had thought. We're likely to get the full dossier in relation to the data for that vaccine before the middle of the year. So that will be another option later in the year for us, hopefully.
Just a follow-up, if I could, Professor. I guess based on the information that you've got now, if you could have unlimited access to the Pfizer vaccine, would you be happy to have that as our primary vaccine for all Australian citizens? It's just that you don't really have that option because we're limited in terms of numbers.
Well, I think it's pointless having that sort of hypothetical debate. We've got what we've got, and we've got the Astrazeneca, and it is effective enough, particularly for severe illness, but also for efficacy against illness altogether, to be of great value. And the fact that we could make it here in Australia is really the trump card. Just to finish off there, Daniel, we do also have the COVAX facility. That's something we signed up to last year. That's had two elements to it. One is us contributing to vaccines for the rest of the world, but it also allows us the opportunity to bid, if you like, from within the COVAX facility, which now has hundreds of millions of doses of different types of vaccines, up to to cover up to 50% of our population. So we are putting in those bids. It may well be that they have Pfizer and they have Moderna, they have AstraZeneca, they have J&J and others in that group. So we'll be able to access from that source as well. Paul Karp is on for The Guardian.
Thanks very much. Can you please give us an update on whether ivermectin is an effective treatment and prevention for coronavirus, and is it responsible for a government MP to promote it as such? And secondly, do you foresee Australia needing to do a second run of vaccinations with Pfizer or something else, so that we don't have two classes of Australians, those that got AstraZeneca and those that got another vaccine with greater efficacy?
So to do the last one first, we are embarking on a long-term journey in relation to vaccination against COVID. We have no evidence yet about how long any of the vaccines, including the Pfizer and Moderna vaccine, last in terms of immunity. The main reason for that is they're brand new vaccines, and we haven't had the follow-up data that we would normally have in relation to that. I don't know how long these ones will last. Any of the vaccines that we have in our portfolio. What I'll say is that there is also no evidence that you cannot. Too many negatives there. The positive is we can follow up with any of the other vaccines next year once they become available, and more will be available to us in 2022 than is currently the case. I have a very strong feeling that Novavax or one of the other protein vaccines will be the long-term option for vaccination for the world, but they, as I said, take longer to be manufactured and longer, therefore, for the data to come through about safety, quality, and efficacy. So we have these rapid new versions, but we don't know about the long-term element for that. In terms of ivermectin, I was actually involved as a researcher in early clinical trials in relation to ivermectin and river blindness in Africa, and so it definitely works against river blindness, or otherwise known as onchocerciasis. It has uses in many other parasitic diseases, including scabies, and we're using that in the Northern Territory. There is no evidence at the moment that it has any benefit or any use in relation to the prevention or treatment of COVID-19. In terms of what backbenchers from one side of Parliament or the other say, that's a matter for them. Steph Dalzell is from the ABC.
Thanks, Professor. Thanks for taking our question. Professor Chen tweeted that if you were in charge of a vaccine manufacturer, would you send your supply to a country where there are thousands of deaths a day, or would you send your supply to Australia? Does Australia's success in navigating the pandemic partially play into why we've only secured a limited number of doses of Pfizer's vaccine?
So we have the doses that we have on the basis of the contractual negotiations we made many months ago with that particular company. We posed the question to them, how much vaccine could you give us in the first half of 2021? And they gave us an answer, and then we negotiated on the price. And that answer was 10 million. And we are continuing and having many conversations with them, not only in relation to the TGA's conversations on regulation and making sure that the data is coming, but also any possibility that we could increase that number. At the moment, that's what it is, and frankly, there are other countries in the world that need it more than we do right now.
Professor Kelly, can I also just follow up on Paul's question about Craig Kelly, a man with the same name but different views? You said that opinions of backbenchers are a matter for them. However, you've been quite outspoken about opinions of doctors today. Craig Kelly is a member of government. He's also said that betadine could be 84% effective in reducing the number of COVID-19 hospitalisations. He published a study that hasn't been peer-reviewed saying that masks were akin to a crime tantamount to child abuse. Are you frustrated with the messaging that he's sending out on social media?
Well, firstly, he's no relation. I can absolutely guarantee that. He needs to decide what is the appropriate thing for a Member of Parliament to be commenting on. I'm not going to talk further about this because it just gives prominence to views that I just don't agree with and are not scientifically based.
Can I give a follow-up question on that point?
Sure.
I think this is, given Paul Carter's asked about ivermectin, I think there's a logical question. Are there any grounds to tell Australians that hydroxychloroquine is a viable treatment for COVID-19?
So there have been many studies in the use of hydroxychloroquine, and in fact early on there was some hope in terms of that, and there were some small studies done for treatment in France. But subsequently there have been many studies on hydroxychloroquine for both treatment and for prevention of COVID-19, and at this point there is no evidence that it is useful for either of those things. I'll just go to Natasha Robinson from The Australian.
Thank you, Professor Kelly. Just in relation to the supply of the Pfizer vaccine, why is it that the EU, given that Pfizer are doubling their production and the EU just negotiated 300 million extra doses for themselves, why is it that Australia can't get more doses of Pfizer? It does seem that other countries are currently getting more when they're negotiating with Pfizer.
So, as I said, we're in virtually constant discussion with Pfizer. If there were more doses available to us, then we would look into whether that was a feasible option for us to get more. So far, that is not the case. I put it to you that the EU has also pre-purchased 400 million doses of Astrazeneca. The US has pre-purchased 300 million doses of Astrazeneca, and the UK 100 million doses of Astrazeneca. So we're not an outlier there. Brazil, similarly, hundreds of millions of doses have been pre-purchased. Many other countries right throughout the world have done that, and in the UK, AstraZeneca is being used. So back to the previous point about what can be used in this case, AstraZeneca has its place. It will save lives, and we have plenty of it here, plenty to give 2 doses to the entire population of Australia during 2021.
Why is it that other countries can get more but we can't?
I don't have an answer to that, I'm sorry. And I think I'm going to have to leave it there. Thanks very much for your interest.